Hi, everybody. Welcome to our MD Stewardship webinar. So today we're going to be talking about PICC lines versus midlines. So if you have any questions or anything at all, please put it in the chat. I'm Dr. Horn with infectious disease. So we take recommendations and any questions. And there was a question about PICC lines versus midlines. And I think this is a good topic. I think we haven't discussed this topic before. And so the question was about the difference between PICC lines, midlines, and when should, a midline be placed versus a PICC line, and what are kind of some things to think about when you see patients with midlines or PICC lines or, um, the differences just in general. So I think this is a good topic. So we'll go through this, and if you have any questions at all, or um, anything that I'm leaving out or anything that you want to add, please type it in the chat, and I'll be sure to mention it. So first off, when it comes to we're going to be talking about central lines. When it comes to central lines, what is a central line? PICC lines are peripherally inserted central catheters. So what makes it a central line? So here I just want to include this briefly just to say that central veins consist of subclavian, innominate, brachiocephalic, and superior vena cava. We're talking about up here, the upper body, because we're going to be talking about these types of lines. But when it comes to central veins, so central veins don't have valves. And so the peripheral veins have valves. And as you move, the blood gets squeezed from your muscles and from moving. And the valves allow the blood to travel back to the heart and not go the other direction. And so central veins are the veins that are in this box up here, the red box, that are central, and they don't have valves. So when we're talking about putting a line into a central vein, it's into an area that doesn't have valves. And why is that important, or why would we want to do that? Well, you'd want to do that because you want to get whatever you're giving, any of your medications, you want it to get in and not sit and not kind of dwell in an area that has valves. And the reason is because there are some medications that can be kind of caustic, and they can be irritants and cause problems if they're just sitting and not moving in a vein. So if it goes into a central vein that doesn't have valves, the blood moves faster. It's not just sitting, it's not dwelling in an area that will cause a problem. So central veins are without valves. So that's the important thing to know about the difference between a central line and a peripheral line. So we have central venous catheters like this picture here that goes into a central vein and it ends in a central vein. A peripherally inserted central catheter, so a PICC line, goes in peripherally to an area that has valves, but then it travels all the way to a central vein. So the tip of it is going to be in a central vein. So you have a central venous catheter and then a peripherally inserted central venous catheter. And a midline, which we'll discuss, is all peripheral. So I have peripheral IVs, and then a midline is also peripheral. So on the left, we're going to have a PICC line. So peripherally inserted central catheter, it's inserted the right basilic vein through the axillary and subclavian veins and into the superior vena cava. So it's the right basilic vein here. It's inserted, and then it's a peripheral. It's inserted peripherally, and then it goes up, and the tip is central. And then a midline, to contrast that with a midline, we have a midline here. It's also inserted into the right basilic vein with a tip just below the axilla. So it starts and it ends peripherally. So then the question would be, well, why do we want to give a midline instead of just a peripheral IV? Well, the peripheral IVs fall out more easily, and a midline is more secure. So a midline isn't just gonna, fall out really easily. And so you can use a midline, and you can also draw your labs from a PICC line or a midline. Here's another picture. So the catheter entry site for both the PICC line and the midline is peripheral, but then the catheter tip. So the PICC line on the left here it ends centrally, and then on the right, the midline it's all peripheral. So we'll talk about a little bit about the risks and benefits of each one. And so the PICC line, thin flexible tube inserted into a vein in the upper arm and threaded into a large vein on the right side of the heart called the superior vena cava. So it ends in the superior vena cava. Then I wanted to also have some pictures. So you can see the PICC line is very long. And the PICC line, it goes in really far. Most patients are pretty concerned, when we start talking about PICC lines, about the pain. Is it going to be painful? Is it going to be uncomfortable? The PICC teams are very good and they put them in very well. And when they put them in, usually, I'll see the patient afterwards and they'll say, "Oh, that wasn't a problem at all." They're very nervous that it's going to be a lot of pain and be a big deal. But, I try to reassure them that, patients do extremely well on them, and the PICC teams are excellent. So when they put it in, you can give IV fluids, blood transfusions, chemotherapy, and other things. Chemotherapy, some types of chemotherapy can be given through a peripheral line, and some has to be through a central line. Now, usually when people get chemotherapy, they'll they'll need some kind of a line usually, whether it's going to be a PICC line or a port. So when they go get their chemotherapy, they're able to get it through a line and they don't have to get stuck every time. I have had patients that didn't want to get a port and they said, "Can I just get a peripheral IV each time?" And the oncologist said, "Yeah, that would be fine." They didn't have their chemotherapy too frequently, and also it depends on what they're getting, but they didn't want to get a port, and I understand the reason. A port, if a port gets an infection, it's a little bit more of a hassle, a little bit more taking it out compared to a PICC line. If a PICC line gets infected, you essentially just take off the tape and then pull. Whereas if a port gets infected, it's a little bit of a bigger deal. It also leaves a scar. Oftentimes when people have ports and they have chemotherapy, if we see someone with an infected port, the first question from our standpoint is usually, is it infected? Can it come out? And when we ask the patient, "Do you need the port anymore?" Usually people will say, "I'm not sure." And whatever time within their chemotherapy, they always say, "I'm not sure." So they'll either say, I have another CT scan or a PET scan coming up in 6 months or a year. So they're either using the port for active chemotherapy, or after they're finished, they have surveillance. Usually with a lot of types of cancers, they have surveillance. They have scans every so often for about 5 years or so. So they'll say, "I'm not sure. I have another scan coming up in 6 months or a year." And then even after they've completed everything and completed their surveillance, we'll ask, can the port come out? And sometimes they'll say, "I guess so. I'm not using it. The oncologist just left it in." So oftentimes ports are just left in forever. And as an infectious disease physician, I would prefer if it comes out. So it's not, a foreign body, having hardware in that's unnecessary or unneeded. And the reason is because we get bacteremic pretty frequently. And when we get bacteremic, our immune system just takes care of it. But if there's something like a port or a pacemaker or hardware that's in the body, if the bacteria attaches to it, and if it has a biofilm or it attaches to it and it covers the foreign body, then usually you can't get rid of the infection without taking it out. And the oncologists that we work with, if we contact them and say, is it okay to take the port out? They say, is it infected? Then take it out. And that's good because if it's infected, it really should come out. As far as trying to salvage the port, when it comes to salvaging a port, the first question is usually, is it infected? What is the bacteria that's on it? Bacteria or fungus. So if it's Staph aureus or Pseudomonas or a fungus, then generally the recommendation is to remove it and not try to salvage it, not try to sterilize it and keep it in. If it's something else, if it's like an E. coli, Klebsiella, even Enterococcus, you may be able to salvage it and keep it in. But generally, with these type of infections, we'll ask, does it need to stay in or can it come out? And if it can come out, we take it out. Because salvaging it is a little bit more involved than just taking it out and then giving antibiotics for 10 to 14 days and being done. So here's the picture of the PICC line. I remove PICC lines after the patient has completed their therapy. And these are very simple to remove. And then I also wanted to have some pictures of midlines. So to contrast that with the PICC line. So the PICC line was pretty long, but midlines, you can see how short they are. They just go in just a little ways. And so, PICC lines, midlines, they're both very easy to remove. You basically just take off the tape and then slowly pull it out. And my whole goal when I remove them is if a person is on blood thinners, they may have a drop of blood. And I don't want the blood to get on their clothes. That's the whole goal of when I remove midlines and PICC lines, and just seeing, are they on blood thinners? And then just trying to be extra careful that if they have a drop of blood, that it doesn't get on their clothes, because it's so easy to remove. You essentially just take it out and then we'll put a Band-Aid on it and the patient's good. Now, when it comes to number of lumens, so outside the body, the PICC line splits into 1, 2, or 3 smaller lumens. And here's a picture of somebody with 2 lumens. And then over here, we have a picture of 3 lumens and 2 lumens and 1 lumen. And I don't have any conflicts of interest. I don't have anything to disclose. I took some pictures from the internet. I just essentially found some pictures. I'm not supporting any of these companies that I have pictures of. So, but I just wanted something that was representative, showing 3 lumens, 2 lumens, 1 lumen. Now, when we get put in PICC lines for antibiotics, generally we'll do as few lumens as possible. So if I'm just going to give one antibiotic and then generally they just need 1 lumen. If the patient is getting other things that they need to be infused while they're getting the antibiotic, if they need 2 lumens, if another service is giving something that needs to be infused, then we'll put in 2 lumens. But generally, we'll try to keep as few lumens as possible. And why is that? That's because of things like this. There are studies showing that the more lumens you have, the more likely you are to get bloodstream infections. So multi-lumen central venous catheters increase risk for catheter-related bloodstream infections. So this is just one study, but there are actually other studies showing the same thing, that the number of lumens and the site of access were independent risk factors for catheter-related bloodstream infections. The use of catheters with multiple lumens should be therefore restricted as much as possible. So if the patient only has one thing that's going to infuse, then I'll just do 1 lumen. And so the most common thing that I do is just order a 1 lumen PICC. And midlines, I just do 1 lumen. And then as far as what's recommended to the patient, and then I'll make one more comment actually about the number of lumens and central lines. So when it comes to choosing, and we'll talk a little bit more about this also, choosing, should I put in a midline or a PICC line? Now, midlines are peripheral lines. So it wouldn't go down as a central line infection. And that's just something I wanted to mention with, if I'm choosing a PICC line or a midline, we'll talk a little bit more about the risks of each one. But if I'm choosing one, if I can put in a midline, I would prefer a midline because there's the risk of having an infection from a midline is lower than from a PICC line. Now, there are some studies showing that midlines are higher risk for clots and thrombosis. Um, so personally, I'd rather have a peripheral clot than an additional infection. But also from a hospital point of view, you're not really supposed to put in midlines to avoid central line infections, but I would actually just think of it as that's one of the benefits of putting in a midline is that you're less likely to get an infection from it or cause an infection. So as far as the patients, now when patients have PICC lines, what do we recommend to the patient? Keep it clean, dry. If you have a PICC line, it says don't do any activities that make you sweat, and that's probably because of the plastic that's there and not having it come off. Don't swim or go in a hot tub, play contact sports such as football and soccer. The question I usually get is about golfing. I'll say, can I still go golfing? And I don't recommend it because I recommend not doing anything to the extremes of motion. So if someone's reaching, that we've had people that stock things in warehouses, and that can be difficult because if they're trying to do things extreme of motion, then it increases the risk that it's going to come out. And one major point that I want to point out is if it comes out at all, not to push it back in. So sometimes people will say, "Oh, it came out a little bit." So if they're moving and it comes out, then I don't recommend pushing it back in because once it comes out, it has bacteria on it. And if you push it back in, you're going to be pushing that bacteria back into their veins. So if it comes out, if it's still usable, you can still use it, just don't push it back in. You have to secure it where it is and then use it from there. But if it comes out a lot, then the recommendation would be just pull it out the rest of the way. We would pull it out the rest of the way and then place a new one if they need it. Now, I included some charts like this, PICC line versus midline. And a lot of this we already discussed, the insertion site, the procedure. These are less invasive than, this is comparing it to a central line. So midlines are used for short-term to intermediate-term access in patients requiring IV therapy durations from days to weeks. So generally, if a patient needs antibiotics, from my standpoint, antibiotics for days to weeks, if they need it to be IV, then I would put in a midline would be preferred. So antibiotics, fluid electrolytes, blood products, and chemotherapy, and it depends on the specific medication. Ideal situation for midline patients needing IV therapy for extended periods of time, needing peripheral IV access, situations where central line risks outweigh the benefits, and administering compatible medications that are not concentrated or irritating to peripheral veins. Now, PICC lines, long-term IV therapy. So generally, when you're deciding whether to put in a midline versus a PICC line, is how long does it need to stay in for? How long is it going to be there? So PICC lines are ideal for patients needing continuous or frequent IV medications. So if a patient has osteomyelitis and they need IV antibiotics, well, the first question with osteomyelitis is, do they need IV or can they take PO? If they need IV antibiotics, then what is the duration? If it's long, if it's going to be four to 6 weeks, then we'll put in a PICC line. If it's going to be shorter, or we're going to give them IV at first and then go to PO, I would put in a midline. And the duration, so it depends on how long you're going to use it for, and then it also depends on your hospital policies and procedures. So we'll talk a little bit more about the durations in just a moment here. Now, advantages of PICC line for long-term treatment. So the durability, PICC lines are can last a long time. They reduce risk of phlebitis compared to peripheral IVs. PICC lines have a lot less phlebitis. Improved patient mobility. This is compared also to a central line and ambulatory care. Midline catheters are preferred over PICCs for either difficult peripherous venous access and frequent phlebotomy. For use less than, so here it says 14 days, although the FDA approved them for up to 30 days. So this is the part of the duration that, the FDA approved them for up to 30 days, but after the first 14 days, there's an increased risk of clotting and malfunction. So clotting, so getting a blood clot there and not working. So where I am, our hospital policy says that a midline should only be used up to 14 days. So according to our policy, it's 14 days, but FDA approval is up to 30 days. So this is where you try to look at the risks and benefits of midline versus a PICC line, because the risks of catheter clotting and malfunction after 14 days are increased for a midline. It's probably because, that in the lumen, we were saying how that peripherally you can have blood that is more stagnant than centrally. So the blood is kind of sitting there, especially if a person is not moving their muscles, especially if they're not moving at all and getting the blood to kind of squeeze and pump back to the heart. Whereas, the blood is going to be more stagnant in peripheral veins. So blood that's sitting is more likely to clot. This is kind of how I think about it. Compared to centrally, the blood is moving faster, and since it's moving faster, it would be less likely to clot, is kind of how I think about it. So in our hospital system, we put in midlines up to 14 days when really they can be used longer. Now, midline catheters, when it comes to contraindications, if they have a history of venous thrombosis, if they have a lot of clotting in the past, if they have a restricted blood flow to their extremities or end-stage renal disease requiring peripheral vein preservation. So if a person is getting a lot of PICC lines or midlines, if they keep getting lines over and over, it can cause a lot of scarring. And if you're thinking that at some point, that they're going to be on dialysis and you want to preserve their veins, then you want to discuss it with the nephrologist. How concerned are they? Do they want to try and preserve? How are they okay with putting in midlines and PICC lines? Now, midline is not a central line, should never be used to continuous vesicants, TPN, chemotherapy. And some places they have a list like this. So I found a list of things that it would say to avoid with midline catheters. Now, some of these have an asterisk and it says maybe okay in the short term. Really, I think of really anything can be okay, I think, in the short term. It depends how caustic it is and how much of a problem it would be. As far as antibiotics go, it has nafcillin, oxacillin, and it also has ampicillin sulbactam here, although they all have the asterisk and says in the short term it's okay. I've given all of these through a midline and haven't had any issues, although yeah, I mean, if you're trying to look at the cost benefit, like the risk and benefits of putting in a midline versus pills versus a PICC line, midlines can be very good. And I included some information here just kind of for completeness, these slides will be available to everybody. Now, patient-reported complications related to peripherally inserted central catheters, a multi-center prospective cohort. So again, the first thing that we want to, before putting in any lines, the question from my standpoint would be, do they need IV antibiotics or can we give pills? And we've discussed before about how pills can be a very good option and in many types of infections, and not just for what we usually use pills for, but also for osteomyelitis and things. The future of infectious disease is going to be giving a lot more pills and not as much IV. And over 60% of patients report signs or symptoms of possible complication or adverse effect after a PICC placement. So bothersome complications from a patient perspective, they're more common than those typically rise to the level of healthcare provider attention or concern. So it's pretty bothersome, but they may not report it. So making what is the risk of putting in a PICC line versus not putting in a PICC line? It just makes you think about it's more bothersome than the studies would suggest. Comparing complication rates of midline catheter versus PICC lines. This was a systematic review and meta-analysis. So the bottom line is their findings suggest patients who use midlines might experience fewer catheter-related bloodstream infections. So I think that's a big deal because preventing infections is very important. The use of midline catheters was associated with greater risk of superficial vein thrombosis. So this is kind of the pros and cons, right, of choosing a midline versus a PICC line. Now, I personally would, if I were going to choose a midline versus a PICC line, I would want a midline. I would want a midline over a PICC line if it were up to me, especially if I was having a short duration of antibiotics. If I had to have IV antibiotics, I would prefer a midline to a PICC line, although it kind of depends on what medications you're getting, what all is the situation. But if I were to choose a superficial vein thrombosis or infection, I would prefer superficial vein thrombosis. Now, safety and outcomes of midline catheters versus PICC. So this is another one. This is another study. In this cohort among patients with placement of midline catheters versus PICCs for the short term, midlines were associated. Oh, my light turns off if I'm not moving. So midlines were associated with a lower risk of bloodstream infection and occlusion compared with PICCs. Whether DVT risk is similar or greater is unclear. So this is another study showing that midlines are associated with lower risk of bloodstream infection. So this is what you want to see. You want to see multiple studies showing similar findings. So that's a little bit about PICCs and midlines. Any questions at all? Anyone with any experiences with midlines or PICCs that they want to share at all or discuss? Question, can you draw blood from a peripheral IV? So when it comes to cultures, all blood cultures are going to have its own stick. So blood cultures are going to be a new stick each time. So it's going to be a needle stick in one arm and then in the other arm. And actually, one thing about I just want to mention also when it comes to cultures, it's going to be new sticks each place. And our facility actually says not to draw blood culture. We used to draw blood cultures, one from the PICC and one peripheral, or one from the port and one peripheral. But our facility actually discourages that. And the reason is because sometimes you'll get like coag negative staph from one of them, and then it's hard to tell, is that an actual infection or not an infection? And sometimes it goes down as, I think a catheter infection when it's not. But also, if you draw two peripherally, it should show up. It should be, if you have positive blood cultures, if you have one from the port and one peripheral, they used to do time to positivity, meaning if it were positive a lot faster than the peripheral, if the blood culture taken from the port or the line is positive much faster than the peripheral line, then you could implicate the line, saying that the line is probably infected. Although if it's positive, it's probably infected anyway. And so they used to try to look at colony counts if there's more bacteria from the central line versus the peripheral. But colony counts weren't the way to do it. They really agreed on time, so time to positivity. But if it's positive at all, I would still say it's infected, even if the line didn't. Now, usually, if you're going to have blood cultures go positive, the line is going to go positive as well as the peripheral. But if you did two peripheral sticks and then they're both positive, or even one has something like MRSA or MSSA, I would say the line needs to come out. And then you would continue on antibiotics, redraw blood cultures again, and then go from there. Um, Now, if you're trying to salvage the line, if you grew something like E. coli or like a strep, I would always give antibiotics through the line. So it's not just peripherally, but through the line to get the inside of the lumen. Um, but generally people uh, don't draw blood from a peripheral IV. You draw blood from a midline or a PICC line. But so if someone is a hard stick, then that's one of the reasons you'd put in a midline or a PICC line is to draw blood from it. So a CBC or BMP, uh, generally you don't draw blood from a peripheral IV. You do a new stick each time for a CBC and BMP. All right, sounds good. If anyone has any questions or anything at all, please send me an email. All right, thank you very much, everybody.